Good afternoon to all of our attendees. We're just going to give it a minute or two for Zoom to let everyone in. Okay. Good afternoon. I'm Matt Vallière. I'm the Executive Director of the Patients' Rights Action Fund, or PRAF. For the benefit of some of our allies with disabilities, I'm a late 30s man of color, black wavy hair, shaved face, olive complexion, wearing a blue and red checked button-down shirt with a knotty pine background behind me. We have panelists for you today who will provide an expert conversation on their professional medical and advocacy perspectives on a few different themes related to the issue of assisted suicide laws. First, we have Kathryn McCulloh, who's a registered nurse. She worked in ER, neurosurgical ICU, and community health nursing prior to leaving the clinical and community health arena after developing multiple disabilities. She's the founder of the National Organization of Nurses with Disabilities, or NOND, and currently serves as the co-director. Dr. Joe Marine is an associate professor of medicine and the vice director of the Division of Cardiology at Johns Hopkins University School of Medicine. He's also chief of the cardiology department for Johns Hopkins Community Physicians. We also have Dr. Kathryn Moseley. She's a clinical bioethicist and board certified pediatrician and neonatologist. For 11 years, Dr. Moseley was the director of bioethics for the Henry Ford Health System in Detroit and has been on the faculty of the University of Michigan Medical School for over 20 years. She also served on the Council of Ethical and Judicial Affairs at the American Medical Association for over 7 years. Dr. Angela Guarda is an associate professor of psychiatry and behavioral sciences at the Johns Hopkins School of Medicine and has been the director of the Eating Disorders Program at Johns Hopkins Hospital since 1997. And I'll be your host today, again, Matt Vallière from the Patients' Rights Action Fund. We also have on an American Sign Language interpreter for those who would benefit from that. A little housekeeping. Rather than presentations, this will be a conversational format. We have some themes and questions, some aimed at a particular panelist, but others should not hesitate to chime in of the panelists. We will take audience questions via the Q&A function. So if you move your cursor around, you can see at the bottom there are different options. To the right, you have two little bubbles with the letters Q, ampersand, A. And you just click that and it opens a box and you can ask questions by typing them in there. Please type the question, your name and organization affiliation if you have one. If you're from the press, please advise which outlet. We'll do our best to get to questions toward the end of the webinar and provide answers via email for those questions that are not addressed today. For any further media requests, please contact Bill Pierce at wpierce@APCO, that's APCO worldwide.com. The session will be recorded and we'll share the link on our platforms afterwards. Panel and hosts, for anyone who's not speaking, please do keep your mic on mute and then unmute it when it's time for you to talk. If you can benefit from closed captions, here's how to turn them on. If you just move your cursor around once again, you can see the little CC symbol. But if your options are so many that it says at the very far right, ... with more, you push that and you can push show subtitle. And it will show the subtitles at the bottom. We have a live closed captioner for accuracy. And you can also click the subtitle settings to make those words larger if that's helpful to you. Okay. So I think that's all the housekeeping we have. Sorry, it was a little long, but I want to start off with just kind of a general question to the panelists. Why should medical professionals and their patients be concerned about assisted suicide laws in the first place? Why is it concerning to you as a medical professional? And what is it concern? Why do you think it should concern your patients?
Well, I'm happy to start. When I speak about this subject, I give 9 reasons. I could probably come up with more. I'm concerned that this is unethical. It's never been part of the practice of medicine. It's not medical care. It's never been a component of medical care. It's never been, there's no guidelines. There's no, the standards that we use to introduce new treatments and new therapies to patients has never been applied to this. It's dangerous. The laws all have so many loopholes, and we can discuss this. It's based on false ideas about prognosis that physicians and clinicians cannot accurately apply to patients. It's discriminatory because it creates a whole new class of human beings who are defined by having disabilities or advanced illnesses. Mm-hmm. It's unnecessary because over the past 30 years, certainly we've had such great improvements in our ability to care for patients near the end of life. It will inevitably lead to other forms of euthanasia. It won't be practiced by most doctors. And I think probably most importantly, it'll affect everybody. This is framed as a choice. It'll inevitably become an expectation, and it will inevitably damage the ethics of the practice of medicine and nursing in ways that will affect all patients.
Mm-hmm.
I couldn't agree more. We are just at a phase where we're beginning to introduce palliative care, and palliative care is beginning to grow and people are understanding what it is. And now in the states and countries that have assisted suicide, palliative care is getting less funding because of assisted suicide. And patients are very confused and won't go to hospice for fear that they're really going to be killed by their doctors.
I think that the issue for me as a nurse is that that's the whole focus, and I want to follow up with what Joseph had said. The whole population that is targeted for this are people with disabilities, and everyone within the disability community. It also intersects with persons of color, the LGBTQ plus community, Hispanics, and so forth, the most vulnerable populations in this country. And to a certain extent, although you may or may not agree, it seems as though the message is loud and clear. If we are a person with a disability, we are disposable. And I think there's a loss of humanity in the physician-assisted suicide laws.
As a psychiatrist, I would just like to add to what Karen said. It's beyond individuals with disabilities. Individuals who have mental illness are especially vulnerable to these laws, as are the elderly, in the sense that they often feel like they are burdened to family or loved ones caring for them, and may be unwittingly convinced to pursue this as a solution to, for instance, psychic distress or treatable mental illnesses.
Yeah.
Wonderful. Thank you all. That's a very helpful perspective. Just for those of you asking for the spotlight of the ASL interpreter, we did do that. There are also various options that you can pick if you go to the top right corner of the screen in your view. And that would be maybe helpful to some people to just try different ones that may work best for you. Mm-hmm. The next question is, what would you say to a medical society considering a shift of position on assisted suicide laws from opposed to quote unquote engaged neutrality, which some state level medical societies have taken on this position?
This is Karen, and I just want to say the first question I would ask is, why are they doing that? And also, who is at the table in this discussion? Because I do not think that you can exclude people with disabilities in this discussion. And oftentimes, the medical society becomes more paternalistic or maternalistic, making decisions on people for people who have not had a voice in their decisions. So I want to know who's at the table and why are they moving in that direction?
Well, I would agree with why are they moving in that direction, because neutrality is really an assent to the process. One is not neutral about, one may be neutral about the color you're going to paint your living room or whatever, but you're not neutral about, say, your children playing in the freeway. This is obviously something that a medical society should take a firm stand on. And as we said earlier, this has never, ever been part of medical care since the time of Hippocrates. And at a time where they had rather few options to relieve suffering and pain, and all they could do was sit at the bedside for however long it took for the individual to die. Now we have all kinds of medications, interventions, and whatever. And it just really begs the question of why on earth now of all times?
I would agree. It's hard to understand how a medical society or nursing society or any medical professional society can be neutral on a fundamental matter of ethics. The way that this is often interpreted is when a society does switch from opposed to neutral, it is interpreted by the legislature as assent. And I saw this process happen in Maryland in real time. I think the other thing to be aware is this campaign to have societies declare neutrality in the issue is part of an organized campaign by the proponents of these bills, because they understand very well that organized opposition of the medical profession is one of their chief roadblocks to getting these laws passed. And so this is the way they neutralize the medical profession, and it is interpreted by many legislators as assent.
So oftentimes I've seen proponent activist physicians within the state medical society propose having some kind of a poll on the membership to see where they might stand on the position of the society. Have any of you had experiences with those polls or how they're framed, how they're phrased, and whether or not that they're truly indicative of either what physician sentiments are on the issue or what position should be taken regardless of physician sentiment?
I would like to just bring up the research that was done at Harvard Medical School with Massachusetts General. And the article I read was February 2021 that identified more than 82% of physicians identified people with significant disabilities as having a lower quality of life. And that's a very scary thing, because who should evaluate who has a quality of life except the person that is actually being evaluated. So the issue for us and my organization and many other national disability rights organizations have a theme that says nothing about us without us. And I think that when we get to this point where we are not engaged, we are capable of being engaged, but the perception is many times of people with disabilities, we have lower abilities and less expectations are put on us. So I think there is a movement in this country from the disability perspective that we have got to be included. And if we don't do that, more of us are going to die.
Thank you for bringing that up, Karen. I learned a little bit about this as I've learned more about these laws and discovered this phenomenon that's sort of the so-called disability paradox. And it's really a fascinating literature that people who are not disabled often theoretically would rate their quality of life if they were to have a disability much lower than people who are actually living with that disability.
That's true.
So that's a very important phenomenon to understand, and one I've learned much more about, and one reason why I think we have to be careful about physicians' involvement in this process.
Yeah.
I would just go ahead, Karen.
No, I just wanted to say thank you, but there's so much research on this, a lot of it that is old, but the older research says physicians will see people with disabilities as having a lower quality of life. Nurses will see people with disabilities as having a somewhat higher quality of life. But if you ask the people with disabilities, they feel as they have a pretty good quality of life. And so that disparity is a part of a bias or a ableism that is scary, because you have the survey that was done by Harvard and Massachusetts General that was dispersed across the country. There were every specialty of physician was represented in almost every state. And when we had that concern where you have over 82% seeing me, I'm a person with significant disabilities, having a lower quality of life, I wish they would talk to me, because I don't feel that way at all. I feel very lucky.
Well, thank you again, Karen. And I would just add about getting back to Matt's specific question about these surveys, because again, I saw this happen in my state in real time, and it was very clear that this survey was written by proponents in what I would say was a biased way, not a scientifically neutral way. There are certain scientific techniques for delivering unbiased surveys, and this just didn't follow that at all. For example, it gave in the multiple choice, it would give you several ways to support or be neutral on assisted suicide, and only one answer that would oppose, just as one example. The other problem is sampling size. The survey was sampled in my state, and only 2% of physicians responded to it. That would never be accepted as a representative survey in any scientific literature. And we can certainly assume that the proponents were very active in getting their friends and like-minded colleagues to respond, where there was probably no such similar activity on those who were opposed. So I think you have to be very careful in interpreting those surveys. The final point that I would make is that many physicians just don't understand this issue at all. And when they're asked about it in the abstract, particularly if it's in a biased way or using the euphemisms that supporters of these laws use, they may not understand the severity of the danger and the threat to the profession and to patients.
Yeah, thanks, Joe. Yeah, similar here in Massachusetts, where I believe 16% of the membership of Massachusetts Medical Society responded, which is obviously a lot less than the number of doctors in the state, statewide. And unfortunately, the House of Delegates made a decision based on very small sample sizes, as you're saying. So I'm going to move to a different question. As many on this call know, a couple of ALS patients and some activist doctors are suing the state of California to remove the self-administration requirement in the assisted suicide law there, all based on the claim that such a requirement is an ADA violation, Americans with Disabilities Act violation. Firstly, is this tantamount to euthanasia? And the difference being, for those listeners who aren't necessarily as at making those distinctions, assisted suicide, the drugs are prescribed by the doctor. You go to the pharmacy, pick up the drugs, and take them home. And the idea is that you self-administer them. With the self-administration requirement removed, the question is, does that make this whole thing into full-on euthanasia, wherein the physician is the agent of the death? They're direct causing the death by administrating the lethal dose. Do you all think this court case does boil down to euthanasia?
I mean, clearly, having somebody else kill you, I mean, let's just put it in what it is euthanasia. However, the way many of these laws are written, that could happen anyway, because the doctor is not there. It's not planned for the doctor to be there. So a friend, a relative, or whomever could, quote unquote, help the person take the medication. This is just codifying or, enshrining it in law that someone else can do that, which just opens it to all kinds of abuse and coercion.
Fair enough.
Very good point. And I agree. And I do agree that this is the slippery slope into euthanasia. And, certainly if you're a judge or a panelist looking at this and you believe that this is medical care, well, then you ask the question, how can you deny it to somebody just because they can't swallow 100 pills or the pills swallowed in a liquid? It really doesn't make sense, and it seems unfair. And that's the pathway that leads you down to greater and greater expansion to people who can't swallow the liquid, who can't swallow anything, and then to people who can't make decisions for themselves. And we've seen that this go down this slippery slope pathway in every country that's introduced assisted suicide, in Canada and in the Netherlands and in Belgium.
Yeah.
In the Netherlands, in fact, there's the participating physicians report every year to the government, and some of them pretty brazenly, to my mind, they report the fact that they euthanize people non-voluntarily, and also without knowledge. So the patient could be not have capacity or not even be awake. And if the physician determines that their life is not worth living in their own personal estimation, then there's some every year they kill people like this. So and
I think that just reflects the fact that once this idea is accepted as medical care, I mean, because we do give patients therapies in an emergency situations where they can't give consent for themselves. We do sometimes make decisions on behalf of critically ill patients together with their families and their proxy about the best care for them when they can't make decisions for themselves. So once you accept that this is medical care, all this extension becomes inevitable.
I agree.
So, Karen,
Yes.
I mean, this question is directed specifically at you. Is the self-administration requirement an ADA violation, in your opinion?
Of ADA?
Yeah.
Okay. Well, first I have to say I'm not a lawyer, but I certainly have
Of course,
an opinion. I have an opinion on it.
I figured you did.
I don't think ADA, and from the very beginning, when the law was enacted in 1990, ever visualized physician-assisted suicide, whether the drug was provided for self-administration or the drug is given to someone, ever envisioned that the ADA would be used this way. So I think that that's one of the biggest mistakes, is to say that it's an ADA violation. Are you kidding me? ADA was developed to enhance and promote the lives of people with disabilities to be independent, directed toward their access to education, employment, live in the community, to their health care, not to receive doctor-administered lethal dose of medication. So I feel as though that the violation is really legally is to even use that lawsuit. I think we're talking about the Shavelson MD versus California. Is that correct?
Correct.
Yeah.
Correct.
I mean, I can't imagine. I know some of the people who are policy writers for the ADA, and I can tell you that this is not what ADA was meant to do.
Yeah,
So,
something similar that Diane Coleman, our friend from Not Dead Yet, had said when this case came out. She's like, it just turns the whole thing on its head.
yeah.
If not providing equitable suicide prevention care is, as Joe was saying earlier, is like as you accept this thing,
Yeah.
then there's kind of no real bounds. But what you end up with is a two-tiered system of medicine. Some people get suicide prevention, some people get suicide help, and it's always resulting in death to the devalued group, right?
Yeah.
So the next question is, why is it important for conscientious objectors to have the latitude to opt out of this practice? Are medical professionals protected from forced participation? And by extension, are institutions protected from forced participation?
Good question.
I think it's extremely important for physicians to be protected from practices that violate their consciences and then don't accord with their moral beliefs.
Yeah.
I there's a concept of moral injury when you're forced to do something that violates your beliefs that I think is demoralizing and creates a lack of integrity in the individual who's forced to undergo such a process. So I hope that we're going to continue to protect conscience rights in this country. All the laws nominally say that providers are not compelled to participate, and that goes for institutions as well. But I think it remains to be seen how that works in practice. I know in Canada, particularly in Ontario, the government has been extremely aggressive in forcing both doctors, nurses, and institutions to participate, driving them out of practice. So I'm concerned that, again, what we see in other countries, if a practice becomes accepted as medical care, as standard medical care, that it may be increasingly compelled. The other point that I would make is that the laws, as I've read them, specifically exclude discussion of assisted suicide as providing assisted suicide.
Yeah.
So I could see, without violating the law, doctors and nurses being compelled to discuss with patients as an option in end-of-life care, which to most people would be regarded as a violation and forced participation.
Yeah.
I don't know if others have comments on that concept.
I would agree with everything that Joe has said, but I would add that problematically what this will lead to is two categories of physicians. There will be facilitators, and then there will be the majority who may be ethically opposed. And that will mean that patients will be channeled towards, I mean, this is really in some ways also an ideology. I mean, it's an ethical belief. So patients who are at risk may be channeled towards practitioners who are very well-meaning, but who are in favor of this intervention. And that is very worrisome.
Yeah, one of my main concerns on this front personally is there's a case in Colorado State Court where a joint venture religious hospital between two different segments of Christianity, this hospital is being sued by a physician they fired who helped a patient of theirs get assisted suicide drugs in contradiction to their employment agreement. If from a patient perspective, I'm not a medical professional in the way that you are. You all have pretty vast expertise. I mean, I volunteer on our EMS squad here in my village, but being a first responder is a whole lot different than what you all do every day. But from that very limited perspective, if I live in Colorado and this physician wins her case, I'm not going to have an option to go to a facility where I know that somebody's not going to help me kill myself in a dark moment, and or have the latitude to suggest such a thing if they don't see my life as worth living, if they devalue me as a person because of whatever. It could be my disabilities, it could be my color, it could be whatever. And they may encourage one thing over another. And similarly, if there are no facilities or providers who you are certain won't participate, especially as when you enter into situations where some patients have HMOs and or they're on Medicaid, it kind of like limits your options of providers. And Medicaid is also in some states where assisted suicide is legal, always paying for assisted suicide, but at the same time denying coverage for sometimes curative treatments and certainly some life-changing treatments for people with disabilities, thereby steering them to death instead of care. So those are my personal concerns on that particular.
Thanks, Madden. I want to just add to Angela.
Yeah, please.
She makes a very good point about patients being directed to those physicians who do practice this. It's interesting that if you look in states where this assisted suicide is legal, very few physicians actually participate in it. In Oregon, where it's been around the longest, it's only a few percent of the state's physicians that actually provide all of the prescriptions. In the District of Columbia, where it was legalized 4 or 5 years ago, it was interesting. They found that out of 11,000 physicians in the district, a year after the law was passed, only 2 physicians, less than a fraction of a percent, signed up to participate. So there's a real disparity between these surveys suggesting a lack of opposition in physicians and those who are really willing to step forward and be part of it, and suggests that the support for it is really much, much less than one would otherwise predict from just looking at surveys.
Sure.
And the troubling part also is that the physician who's prescribing the prescription may not really know much about the patient at all. And that's borne out by data in Oregon, which shows that the average duration of a physician-patient relationship in the prescribing physician for assisted suicide is less than 3 months. So it's not a patient's longtime internist, family physician, or even oncologist or neurologist that's providing these prescriptions. It's really a self-selected small group of those who believe in it.
Yeah, and this is a really important point, because it is not necessarily the primary provider of the patient who's known them for a long time. Sometimes the prescribing provider has not spoken to family. They may not actually know the patient well. And I want to make clear that the providers who are providing lethal medication, they're well-meaning. They believe that they are helping the patient. So it's important to realize that there's nothing devious about what the way they see it. They think they're helping the patient, but in reality, there are subtle ways in which this process can become easily discriminatory based on the experience of that individual. They may not, for instance, be able to recognize mental illness. They may not be evaluating the patient for treatable conditions. They may not understand palliative care. So that's where there's a very high risk that they unwittingly facilitate death in patients who have treatable conditions or whose opinion about requesting physician-assisted suicide may change over time.
Yeah, it's interesting. The proponent organizations used to publish the percentage of assisted suicide prescriptions that they had facilitated, and are making just these very points, that there are kind of these select few that kind of become almost specialized in it, and there are very few of them that are actually super comfortable with this whole practice. So the proponents just stopped doing that because of these very concerns. Stop publishing how many.
I don't want to draw the parallel with capital punishment, but there are very few physicians. I mean, that's a whole problem, right? We know finding someone to administer lethal injections. Not many physicians are comfortable with this because it's fraught with potential problems and with the risk of causing death in someone who has a condition or that's treatable or who would change their mind.
Yeah.
And that's
fair enough.
Yeah.
One of the questions from our friend Carol Sutton at Not Dead Yet, she said, can you speak to the practice of physicians specializing in assisted suicide and euthanasia, like a Shea Wilson who had opened a death clinic in the Bay Area?
Oh.
Similar, I would imagine, similar concerns over that sort of thing as you were describing earlier.
Absolutely. So the question is concerns about physicians who specialize in this?
We're just speaking to the idea that someone would specialize in it. That
Yeah,
like you all have specialties, right? You know, like you're a cardiologist, Joe, or like, you know, Kathryn's a pediatrician. You know, like, is there, for some of these physicians who are maybe board certified in something else, but this is really an area of focus for them, what does that look like for medicine? How does that affect the practice?
well, the concern is that it will become accepted as part of the practice of palliative and hospice care. And that gets to the point that somebody had mentioned earlier about patients then having to fear, is this doctor or this nurse going to help me, or is this doctor or nurse going to end my life because they think it's the best thing for me? So that's the danger of it seeping into the mainstream of end-of-life care.
Right.
And the doctors who specialize in this are not ghouls in general. I mean, we think of Jack Kevorkian. I'm here in Michigan, so I think of Jack Kevorkian. But their whole idea is to relieve suffering. And the rationale that I have heard from several doctors who support this is that in the past, patients would die of their illness, of pneumonia or whatever. And our medical advances have made it such that these patients are miserable, but will not die, to them sadly, in the foreseeable future, and that they are miserable. And if they want to die, it is their autonomous choice to do that. And as their doctor, I should help them do that. And it's odd. It's an odd rationale in my mind, but that's what I have heard from many. It's not that I think this group should die or that group should die, though I'm sure there's some like that. But it's, I need, my patients need to have this option if they want that.
Mhm.
I would fully agree with your point, Kathryn. In my experience, the physicians and even more so members of the public who are supporting these laws are very sincere in their beliefs. And often you hear stories of people who say they got involved because a family member or a friend suffered at the time of death. And it's very hard and sad to hear these stories, but my own response is that these are people who didn't get good end-of-life care. And
Right.
our response as a profession, as a medical community, should be to work to provide better end-of-life care and not short-circuit it with this option.
So, I mean, in light of that, Don Eskew asks the question, this is one of our participants. Since Timothy Quill is the founder of the palliative care department in the hospital in Rochester and pushes assisted suicide and euthanasia across our nation, how do we get the message out to lay people that palliative care is good, but has been hijacked by the assisted suicide lobby, right? And so I guess I'm gonna start off that question with my own experience, is that in going to some 911 calls where there was an end of life circumstance as a first responder, and the person, when you suggest the idea of hospice or palliative care, every single person I've talked to about it that I've had in these calls has been very afraid of hospice care. They think that somebody's just going to come in and kill them. They don't fully understand what all the benefits are. And so there are obviously some really bad stories out there. And in some states, the hospice program is just really broken. I know the LA Times has reported pretty continuously for the last 2 years how broken the hospice network is and some of the abuses of hospice providers in the state of California. But that's not everywhere, and it's not every hospice provider. And so how do we as both lay people and as medical professionals talk to people about these options in a way that puts their hearts at ease about it? I mean, and also what opportunities are there for either policy and government, the House of Medicine, or even just activists and advocates to promote good palliative care, while at the same time recognizing that, yeah, there have been some difficulties with some hospices, and there are some concerns there, and how do we have it both ways, and how do we talk about it in a way that is really clear, so that the assisted suicide lobby can't just hijack what many of us consider a real solution to many of the existential concerns that people express when they request assisted suicide in the first place. Like, pain doesn't meet as we all know, pain doesn't meet those top 5 reasons people request assisted suicide. And so these other things that are driving people to ask for death, many of which are resolvable and through good multidisciplinary, robust palliative and hospice care. But how do we get around these? Like, this is a really tough thing. We've even at the Patients' Rights Action Fund, we've experienced some folks, being, I don't know if upset is the right word, but just like they did not like that we emphasize sometimes that palliative care can be a response to this. And I appreciate and understand those concerns, while at the same time, I do think that it's a valid response as imperfect as it is. So what do we have to say about that? How can we do good in that area?
Well, you know, as we all say, words matter.
Yeah.
And so we confuse the situation when we add things like death with dignity, assisted dying, when we mean assisted suicide, as opposed to palliative care and hospice. Because even with palliative care and hospice, especially in minority communities,
Yeah.
people immediately think, oh, you're going to give up on me.
Yeah.
Oh, I'm not going to get any treatment whatsoever. That's one of the reasons that the AMA did not go. There was a group that wanted to change the name from assisted suicide to something like death with dignity. And we said, that's too confusing. We will call it what it is so that people know. And I think that's the best thing we can do, because the people pushing assisted suicide are going to muddy the water. I mean, the worst one is the one in Canada, which is euthanasia, but it's what is medical aid in dying. Well, so is hospice, so is palliative care, but they are totally different things. I think that's the first thing, is sort of do briefly some definitional differentiation for people to say, this is this, this is that, this is not what we're talking about, and this is what we're talking about.
So we're talking about education, but I wanted to follow up also with Matt, because one of the issues that I see now as of great concern for non-terminal people with disabilities who are wanting to die. And I feel that most of this, maybe 100% of this, is because a society has been neglectful in providing the resources that the individuals need. For instance, the home community-based supports and services, there are some people in the United States eligible for it and others are not. And we saw what has happened during the pandemic with people in nursing homes and in other congregate settings. Many died of COVID. And so there is that concern about nursing home admission at this point. My point is the concern about policy. And I know in Washington, they're working on some of this, and there's a lot of advocates that are working on in the community-based supports and services, but we're also talking about the issue of people feeling like they're a burden. And why are they a burden? Because we don't have, they maybe have a family member that's a caregiver, but we don't have enough caregiver respite. And people know when they are getting worse, they don't want to be a burden to their family. So, I mean, I worked in the South Side of Chicago for off and on about 8 years. And I worked with many people who were in hospice in their homes and their families. For instance, assisted suicide was not even a thought at that point, but they had family members, but there are some people with disabilities that don't have that, and they don't have the income to be able to pay for personal assistance. I mean, last week I called to find a direct care worker, a personal assistant for one of my clients. And the direct care worker needed to know how to use a Hoyer lift that would help move the patient from the bed to a chair and from the chair back to the bed. And it's $20 an hour in Illinois, at least that. And if you need someone for 8 hours a day, 4 or 5 days a week, and then you're alone, potentially, it's a very challenging thing. They do not have the money to pay for the personal assistance. So policy wise is, and you mentioned that, Matt, that's a huge thing. And I think they're working on it. But in the meantime, we have a lot of people that are feeling very isolated, alone, and are not being adequately taken care of. So they want to die.
I think access to care is a real problem. And that obviously is true, like Karen says, for disability. It's a problem for palliative care, as you said, Matt.
Yeah.
But the other problem is that we're talking about suicide. And the data shows that many of the individuals who are asking for physician-assisted suicide have never been evaluated by a psychiatrist.
Right.
And a significant proportion, maybe half, have an untreatable depression. In fact, suicide, requesting suicide or wanting suicide is a cardinal symptom of depression. And the evidence suggests that if you treat depression, most individuals will respond. It's a treatable condition. So that we know that even if you look at individuals diagnosed with terminal cancer, those who request PAS, if treated, a significant proportion will switch to not wanting to die anymore.
Mm-hmm.
So this is where things get really complicated, even in terminally ill individuals. They're even more complicated currently because of the shift in various countries, including Canada, and most recently here in the US with a report of physician-assisted suicide for anorexia nervosa in individuals who have psychiatric conditions and who are requesting physician-assisted suicide, because really mental illness colors the picture, both in the terminally ill with cancer, for instance, or really a prognosis of potentially less than 6 months, but also now increasingly in patients with really any diagnosis, practically any mental illness who request to end their life.
Angela,
let's
talk about that. I mean, this is your specialty in the eating disorders department. What did you think and feel when you read the newspaper that day and you saw that a physician in Colorado had used anorexia nervosa as the underlying condition for prescribing lethal drugs to her patient?
Well, their argument was that the certain individuals with anorexia nervosa meet criteria for terminal illness, defined as a prognosis of 6 months or less, and that they had the capacity to decide rationally whether they wish to end their life using physician-assisted suicide. And there's big problems with that reasoning. One, because anorexia nervosa is not a terminal condition. The problem is that patients are ambivalent and scared of the treatment, which is to eat and gain weight. But nearly all the consequences of anorexia are reversible with weight gain, including a lot of the psychological elements of the disorder, the fear of fatness, for instance. So that even in extreme, what we call cachexia or starvation, nearly every patient is treatable. And the cases described, at least 2 of the 3, did not appear to have had a full trial of treatment from the information that was provided. The other problem is the decision-making capacity in anorexia. Patients with anorexia nervosa appear to have good decision-making capability in every respect but one: their ability to appreciate that they need to gain weight to get well. So they're very scared of doing that. And so if they don't have capacity to accept treatment, how do they have capacity to accept death by suicide? It doesn't make sense, because their capacity is impaired in this one area, being able to decide what I need to get well. And so how can they choose rationally physician-assisted suicide? It's very alarming and very concerning. On top of that, someone like myself, who's treated thousands of patients with anorexia, we cannot predict who can get well and who will die of the illness. This is a highly dangerous psychiatric condition. It has the second highest mortality after opiate abuse, but we're very bad at predicting who will get well or when. Mm-hmm. Patients can get well after decades of illness. And if we reason that anorexia is potentially terminal, then why not substance use? Why not severe depression? Why not schizophrenia? It starts becoming very hard to distinguish where the boundaries are.
Yeah, so I want to see, did the others agree that it's impossible to call mental illnesses terminal, and if you do, then you basically open it up to such a wide variety of psychiatric disabilities that do sometimes result they have high mortality rates, as as Dr. Guarda put it. Are they all eligible?
It's a great point that has been made. The larger issue is how do we define terminal illness?
Yeah.
And there is no good way to define terminal illness. I can certainly say in my field, patients with heart disease can experience heart failure, go through exacerbations, appear to be very, very sick and not likely to survive, but can turn around with good therapy. And we don't have a great way to predict individuals. We may be able to look at a population of 10,000 people and say a certain percentage are likely to die within a certain amount of time. But looking at an individual human being in the eye, there's really no good way to make such a prediction. That's borne out in research that shows that even people who are officially referred for hospice, who have to have a 6-month prognosis to be eligible for hospice, at least 20% will survive 6 months and 10% will survive a full year. And there are other studies showing that in patients not referred for hospice, those percentages are even higher.
And problematically, there's been a slide from terminal illnesses defined as 6 months or less prognosis to unbearable pain and suffering, for instance, in some of the European countries. So you can see how the criteria for eligibility keep expanding slowly or not so slowly.
What do we think? I mean, so are there particular dangers involved when you make that, in my mind, a very cataclysmic shift from actual physical illnesses to psychiatric disabilities? That now, this seems to me like a major game changer, and the fact that Canada is about to be allowing it, as Angela put it, for basically any intolerable situations. Even one gentleman requesting euthanasia in Canada for severe, what he calls eco anxiety. This is like, I'm just kind of curious, what's the kind of general sentiment? How does that change the game?
I don't know if that was a performance piece or it was for real. I just saw that in news the other day.
I think it's real.
You think it's real?
I do think it's real. Yeah, and at least the application went in. I mean, there are a couple of people with disabilities in Canada who requested euthanasia because they don't have sufficient funds through their government assistance to get housing, just housing.
Yep.
So they're being, I mean, to one of Karen's earlier points, like they're being driven to kill themselves.
Well, this has been a reality in the Netherlands and Belgium for years. They allow euthanasia for people purely on the basis of mental illness. There was an article in JAMA Psychiatry published in 2016 that listed the 66 patients and their condition who received euthanasia for psychiatric reasons, including things like anxiety, PTSD, eating disorders, prolonged grief, autism, and depression. There's been some very well-publicized cases of this. And I suppose the rationale is that they believe they're relieving irremediable suffering. And once you've gone down that pathway of thinking that this is a reasonable, rational, and ethical response to irremediable suffering, then I guess it makes sense to you. And it's hard to distinguish physical suffering from psychic suffering.
As a pediatrician, I just always wonder how this norms suicide for teenage angst. I broke up with my boyfriend. They hate me, whatever. And if grandma can commit suicide and that's okay because of angst or depression, why is it wrong? And as they look at lowering the age limits for assisted suicide, I can see this easily happening.
And putting vulnerable people at risk.
Yes.
For sure. I want to ask this question to Karen. you're here today representing the National Organization of Nurses with Disabilities, an
Right.
organization you co-founded. What process did NOND utilize to discuss and then agree on opposing assisted suicide laws?
Thank you for asking that. And I feel very fortunate because last night we had a full board meeting. And I was able to go back to the board where some of them on our board now were not directors, where we made a decision to oppose physician-assisted suicide. It was very interesting because no one in nursing had included in their curriculum anything about physician-assisted suicide, no one. So when my colleague and I first introduced it to a board, we're using a conference call because we're geographically dispersed across the country. And we said, what are your thoughts about physician-assisted suicide? And the phone went dead. And I thought I was disconnected. And then finally they were giving a thought and somebody said, well, I haven't thought a lot about it. Another director said, I don't know anything about it. So we knew from square one that our first process was to educate our own nurses, because we had missed out on a very important piece of education that was not included in the curriculum. And so our very next board meeting, we asked Diane Coleman from Not Dead Yet to be present to us about physician-assisted suicide. She disseminated a lot of information, which I can guarantee you every one of our board members read. And we were in a discovery mode, a journey. And I went back to my notes for 2015, 2016, because we went through a period of 4 to 5 board meetings, and I kept writing in my notes, gut-wrenching, gut-wrenching, gut-wrenching. And I will say that because not only are we healthcare professionals as nurses, we are also people with disabilities, and we are also patients. And some of our directors who are working full-time have very significant disabilities. And under the law, they would actually be eligible for physician-assisted suicide. So we started talking about that. And I was interested in what Joe had to say and some statistics. We had a recently retired board member who actually presented for us at a conference, and we were talking about palliative care. And she has a chronic health condition that's significant. And she was admitted into hospice. And I remember hearing her say, but I failed. And I thought, what is she talking about? She said, I didn't die. And they discharged her.
Graduated.
And so, I mean, these are the kinds of things we have internally in regard to our group of nurses who are really demonstrating what is possible. But we take this very seriously because we do respect the autonomy of personal choice. So we finally, in our journey, we had one gentleman from Oregon who was not supportive of the death with dignity law there. We had other directors doing some research and looking at other states. And we finally had to make a decision. There's a personal side to us that may have a view, but when we get into our due diligence in the governance of our organization, this is an organization where our bylaws say 60% of people would have to be disabled and majority nurses. But right now, as of last night, 100% of our members of our board right now are all nurses with disabilities. So they have a very strong voice and they have very strong opinions. So when we finally went through that journey and that process, we all said, how could we support physician-assisted suicide as an organization representing nurses with disabilities when some of us would be eligible under the law, even as productive as we are, to have physician-assisted suicide assistance. So that was a journey. As I say, it was gut-wrenching because people were just pulling out from their past experiences and patients that they had worked with that were terminal, and they had that, but we have a very wide lens. We're not just looking at that from the professional basis, we're looking at it from the disability point of view as well. So it took us almost 5 board meetings before we came to terms with a vote. And I will have to say that the far majority of people strongly supported our position on the opposition, but it was not unanimous. And I think we have to expect that at this point. People have a lot of different opinions. And I had this discussion last night because we have new directors, and it became kind of a gut-wrenching discussion again last night, because everybody has those memories of the work with people who are terminal. We have had nurses who are terminal. So it hits right in the heart for us. So I'm proud of our board that we came to terms to oppose it, but I have to say it was quite a journey.
Interesting. I mean, so something that I've seen, and I think that you alluded to earlier, is that, as Carol Sutton's asking in the Q&A, the disability perspective is often not heard on this issue. So to give a quick example, there were 19 national and local disability organizations that signed on to an amicus brief to oppose this carve out in a lawsuit that would have allowed assisted suicide here in Massachusetts. This is the Kligler case. You all signed on to it.
We did.
And yet, we have a PR firm on retainer that we let the press know that we have, spokespeople on this thing. They did not cover one iota of the fact that there was a very strong disability opposition to this legal action. And a similar question from Jules Good, also from Not Dead Yet, is how do we interrupt this So the question from Carol is, how do we amplify the disability voice in this conversation? And Jules is asking kind of a similar related question of how might we interrupt ableist perspectives among medical professionals about disabled people's quality of life and introduce a disability neutral or positive perspective into these end of life discussions.
I don't know if I just want to say, I'm not sure I can address that adequately, but I do want to say this, that, and just so I can get it in, we're in desperate need, and we're desperate need, both in medical schools and nursing schools, to have more education directed to 21st century philosophy on independent living of people with disabilities. And that is something from my own experience even over this last year. I realized that physicians were doing things because they just didn't understand. And once they did, it was a different picture. So I'm feeling that having the disability voice heard will also be helpful with more medical schools, including curriculum that is directed towards disability. And some do, some most definitely do, but an awful lot don't, and hardly any of the nursing schools do. So I don't know if that fits in, but I think including education makes a difference that helps our voice be heard in access to quality health care.
Would that kind of I don't know a lot about continuing medical education courses. I mean, would that come in the form of an ethics segment to, your required credits that you would need to get?
Well, I can tell you right now that the National Council on Disability chairperson, Andreas Alagos, who is and works in Washington, he's President Biden's appointee, he's on a mission to be engaged with medical schools to talk about their inclusion of more information about people with disabilities from the 21st century point of view, and also has been in contact with various nursing leadership at the more national level, talking about the inclusion of education. So, I mean, I don't know where you all have with the doctors that are on the panel, and if you had, and you may not understand exactly what kind of education I'm talking about, but one of the very hopeful things about people with disabilities is there's been a revolution in technology. I could not do my job as a person who's deafblind if I did not use assistive technology software on my computer, that I didn't use assisted hearing devices and other adaptive equipment that I need to do my job to be brought up to a fairly level playing field. And I think that, and I'll just give you an example. I don't know if I have it here. I was sent to the emergency room as an example, and I use the hearing assist headphones, much smaller than these, that is attached to a hearing device is this, and I can adjust it. I can make it more, the clarity better. I can adjust the volume. And the head of the emergency room came in and sat down beside me because I didn't think I should be there. I said, I handed it to him and I said, this will help me hear you. And he said, oh, I don't know what to do with it. I've never seen anything like it. And I was going, just talk. I have everything ready for you to use, but it's just a small example that a lot of physicians that either in their specialty, they obviously will know some of that technology, but there's so many physicians that do not know how we function independently. And the technology has made such a difference in our lives. And so but I'm referring that back over to considerations of quality of life, considerations of people wanting to die, and the resources that individuals who are disabled don't know about. And I think that's an important part of giving hope, wanting to live, and having people engaged with us in a different kind of media access. So that's just my hearing assisted device has permitted me to attend meetings, to actually the anesthesiologist let me wear it in the operating room, and they took it off while I was under anesthesia. They put them right back on before I got off the operating table. I mean, there is accommodations now that is getting involved with that technology. So Matt, this is an issue that is continuing to grow with this revolution for medical students and nurses with disabilities and nurses in the workforce. And it's a hope, it's positive, it's
Awesome, Karen.
Those are just such amazing comments. Thank you, Karen. I would just add, I can't really add too much to that except to second that there needs to be more education for medical professionals about this. I would just say that I've learned more about the issues of the disability community participating in this movement in the last few years than I've learned in the rest of my medical career, including medical school. So thank you for your comments and your voice.
Yeah, I would add that was very enlightened, Karen. And I was thinking, listening to you, did I get any such training? Obviously, I trained a while ago, but I remember nothing that fits, that really focused on disability, other than maybe, a couple of days of PMR, of physical medicine and rehab, but really minimal training. So you're right, we are very uneducated in what's available to help quality of life. And this fits into the whole argument about palliative care too. We also aren't well trained in general in palliative care, the average physician.
Yeah, but I think that for me, and then this is not a pity party, I have the dual sensory impairment. I have multiple sclerosis. I have a stent in, and I was diagnosed with cancer last year. I had 3 surgeries within 5 months during the pandemic. I'm cancer-free right now, and all the labs and CAT scans are fine, but it makes you put your life into perspective. And that's why I say I'm a very lucky person, and I feel as though I have a very high quality of life. But I think that I've had a lot of problems with physicians now accepting me and helping to move me forward and getting the treatment that I need now. And I actually had to start, I'm just sharing this with you, you have to know this. I had to start with a new cardiologist because my cardiologist that I loved moved since 2012, he moved to Israel. So I met a new cardiologist, and after the meet and greet, I said to him, I am not a DNR. And he was very wise. He turned to me and he said, are you getting the impression from some of your physicians you should be? And I said, most definitely. So this is how we're having, not everybody is as self-determined or as a strong self-advocate as I am. And that's what's scary for me. I'm being denied treatment now based on the fact that I'm a senior citizen and I have multiple disabilities and complex health conditions. And that's long before I'm terminal. I hope a long time before I ever get that way. But I think we have to come to terms with, particularly in the ageism side of this, where, I have gray hair, but I didn't know I had gray hair until the pandemic and I couldn't get to the salon. So, I found out, I have gray hair. So now I'm a senior citizen and I am now being targeted as we don't want to have to bother with her anymore. And that bothers me a lot. Don't you think it should?
Thank you, Kara. That was awesome. And I resonate with you without knowing that you had gray hair until the pandemic. Thank you.
I was shocked.
Like, well, there it is. But
But-
I think, you know, and I went through medical training years and years ago, but the way things are now, first off, the hours allowed to train are I can't speak, so much shorter than they used to be because of duty hour restrictions and so forth.
Mm.
And I remember, and apparently it still is true, when you go through PM&R, when you go through all of it, you tend to see the worst of the worst. And so in the ones, or if you do your hospital rotations, you tend to see the worst of the worst. And that stays with you. You rarely see people like you who are just coming for a quick outpatient appointment with a regular cardiologist or whatever. And so your mind is skewed, which is a shame. I mean, I really wish, both in terms of diversity and which includes disability, but race, gender, all of these things, that the standardized patients would be used in a better way, such that students who now increasingly, because of the competition,
Mhm.
are basically white privileged Americans, come to med school, and who do they see? Who are they taught by other white privileged Americans, but their patients are not. And so without getting some kind of standardized patient experience
Mhm.
with others, they don't get a feedback of, do you realize with this handicapped patient, you were closed with your head, you know, sitting back with your legs crossed and your shoulder and your arms crossed, and very unapproachable.
Yeah.
Give them that chance. But this has been something that has been one of my pet peeves for years and years, how we can better educate these students who are not diverse into dealing with their diverse patients.
Mhm.
There is
Yes.
a very strong bias reduction in medicine movement ongoing, I think supported by a number of organizations, and I've seen some of that in action. So I think that there's hope that we're going to be bringing more attention to this issue, and ableism is an important component of that.
That's very hopeful to hear.
Yeah.
I'm just very glad to understand that. I was not necessarily aware of that. And I think that maybe, you know, some of the disparities that were laid bare during the pandemic may be helping to fuel that, hopefully.
Yeah.
In line with that same kind of vein of thought, Kathryn, how do you see the disparities in healthcare for people of color and people with disabilities, which were laid bare during the pandemic, affecting vulnerable patients in jurisdictions where assisted suicide is legal?
Well, just even before
Mm.
assisted suicide became legal, especially the African American community, but really all minority communities have great distrust of the healthcare system, because number one, we have people who are living today, I mean, the baby boomers and their parents, who were living under legalized segregation.
Mm.
There were hospitals that when I was little, my mother could not go to
Yeah.
because she was Black. And then you have all of the unconsented experimentation that was done. And so even without assisted suicide, you have a group of people who are very suspicious in terms of organ donation, in terms of end-of-life treatment, having spent many years on ethics committees where, when it was appropriate to start transitioning to palliative care and so forth, patients' families were resistant because of the fear that they were going to give up. You add physician suicide to it, it just gets worse. And I believe, and I'm not familiar, I haven't looked at the numbers recently, but the states where assisted suicide is legal, number one, have a very small African American population,
Mhm.
so it's hard to tell what's going on. California and DC are the only ones that may have a significant one, and I have not seen their numbers. But African Americans and other minor are not rushing to have this done. This seems to be, as one person put it, sort of the command or the domain of middle class, upper class, white, well-educated people who believe that they are in control of everything, and this is just one more thing that they can control.
Yeah, it's interesting.
Not something that people want to, that most, I won't speak for all of them, most minorities, especially African Americans, want to do.
Yeah, interesting on the numbers. I mean, we had a ballot initiative here in Massachusetts to legalize assisted suicide in 2012. In all the working class communities, it was a no vote. I mean, that ranged in percentage. But the most interesting to me is that there are certain neighborhoods in Boston, they break down the voting districts into wards in Massachusetts, even smaller areas. And some wards in Boston are 100%, near 100% Black. And those neighborhoods were voting 70 to 80% in opposition to assisted suicide. Same people voting 80 and 90% for President Obama. I mean, it's just, and I think that those numbers are telling. And also, you look at some of the polls. If you go to the Pew poll from last year, or maybe it was 2020, but a recent Pew poll, yeah, the top lines make it look like, you know, the country is all for this. But you take a look at the crosstabs and you look at demographics and you see that people of color are opposed, and up to 65%, generally speaking. So from that perspective, Anita Cameron has a question that in kind of relation to something that you said. Anita is from Not Dead Yet, for those of you who don't know her. Although the data shows that assisted suicide is not used very much among BIPOC communities, I'm afraid that it is normal, that when it's normalized, our community will be steered towards it due to bias and disparities. Do you agree?
Yeah.
Oh, yeah. Are you asking me?
I am asking you.
I had to double check. For several reasons. I mean, number one, we tend to be less medically advantaged. We are mostly covered by public health insurance rather than private health insurance. We often don't have a personal physician to go to.
True.
And most of us, you know, if you look at the wealth gap between Black families and white families, it is just enormous. So once you start preying on, well, you're gonna be a burden to the family and whatever, people will be coerced into doing it. But we will be targeted. Even to this day, we see, I mean, I stopped collecting them years ago, but I had a pile of papers that probably went up to my hip of all the healthcare disparities between African Americans and whites, getting cardiac interventions less frequently, getting cataract surgery less frequently.
True.
I mean, you just name the intervention and we get it offered less frequently with higher death rates. So this will just be one of them that we might get more of, but more is not better in this situation.
I think make a very important point about trust. If you know, people don't know they can go to an institution and get the care that they want, and that is in accord with their ethics and their morals and their beliefs, they're going to be less likely to seek medical care, and that can then widen disparities. So I think that's a negative impact of legalization that the proponents may not be understanding and contemplating. I practice at the Johns Hopkins Hospital, where Henrietta Lacks was taken care of, so we're very familiar and learn about our legacy and how it has created distrust in our community. And I'm very, very concerned about any action that could be taken that's going to harm that trust.
Excellent. So I'm going to switch gears a little bit to the drugs that are used for assisted suicide. And this question is directed at Joe. What changes have you seen in the drugs being used for assisted suicide? Are any of the results or drug cocktails particularly concerning to you? And would you consider the untried use of drug cocktails on patients without prior testing a violation of international human experimentation treaties?
Yeah, so this is really a remarkable phenomenon that's taken place over the last 5 to 6 years. And we know about it from a few articles in the lay press, and also because Oregon does report which drugs are used, prescribed for assisted suicide on a year-by-year basis. So we have this data tracking. So the drugs that were traditionally used, if you will, were barbiturates, very powerful sedative to hypnotics, a controlled substance. And the typical dose would be secobarbital, about 90 tablets, which is about a 50-fold overdose over what you would take for seizures or for sleeping. So about a 50-fold overdose that would then be dissolved in water or liquid and consumed quickly. Because large overdoses of medications can induce vomiting, an antiemetic is usually prescribed just beforehand. So that was the typical cocktail. However, over the past 4 or 5 years, there's been a huge price spike in barbiturates. And in some places, they're just completely unavailable. And so doctors in states where it's legal have actually been, in my view, experimenting, performing uncontrolled, unregulated, unsupervised experiments using drugs without a labeled indication, really taking advantage of the concept that many drugs in a huge overdose can be poisons, and literally experimenting on people according to their own intuition as to what might be effective and seeing the results. That to me is just unethical experimentation. In my institution, to do any kind of trial or experiment on a patient that even has a tiny amount of risk, I have to get approval from an institutional review board, an ethics oversight committee. I have to give a detailed plan of how I'm going to protect patients. I have to write an extensive consent form that goes over all the potential risks and benefits. I have to report any adverse events to this, adverse events to this board. None of these are taking place right now as doctors undergo this experimentation with new drugs. What they seem to have largely settled on is a combination of digoxin, which is a powerful cardiac drug, which is known to cause arrhythmias, diazepam, which is a sedative, Valium, morphine, and amitriptyline, which interestingly is an antidepressant, which is also known to have pro-arrhythmic properties when given an overdose. So it appears that the method now is less suppression of respiration and to induce a lethal arrhythmia. And again, we don't have any controlled experiments, any oversight, and it's just very troubling to me, and perhaps speaks to the ethics of physicians who would get involved with this, that they would participate in this kind of experimentation, which all of our ethical training teaches us is wrong.
Anyone else have comments there?
I would like to just clarify, when you gave the list, Joseph, of these medications, I don't know what the law is, but does the law permit that type of experimentation when it comes to physician-assisted suicide? You may have said it and I may have missed it, but does the law permit that, an unproved combination of a cocktail to create death? Where is the law on that?
That is a great question. In general, in the United States, physicians and nurse practitioners and physician assistants with prescribing authority have wide latitude in using a drug off-label without a labeled indication for an indication that they think would help the patient. So they're really given broad latitude to use their judgment. So I would say technically it's legal in states that allow it. However, I would hope that in any institution that has an ethics oversight board or an IRB, that they would not allow this to be done without the participation of the IRB. So that technically could be illegal, or at least in violation of hospital or health system rules.
Thank you.
Well, we're getting towards the last 5 minutes of our time together today. You know, I wanted to end with a final question. Medical professionals around the country need to know what they can personally do to push back on this insidious attack against their role as a healer. So, and how they can protect their vulnerable patients. What you all are pretty seasoned advocates on this issue, and we're grateful for you. But the question is, do you have advice for those folks who have not been quite as involved, who are very concerned? What do they need to do as medical professionals in the face of this situation?
Well, I would
Karen?
say education is key, learning as much as you can about it. And the Patients' Rights Action Fund has a great website. You can sign up for updates.
Thanks, Joe.
I've learned a lot about it. I mean, one of you did a document, I think 4 or 5 years ago, where you assembled a lot of information, testimonials, references to articles that was enormously helpful for me in educating myself and preparing my own presentations about it. So there's other communities. Another one that I like is the Euthanasia Prevention Coalition. That is a Canadian organization that gives a lot of good information and publishes, I think, a weekly newsletter to keep you up to date. And there are state-by-state organizations, coalitions that develop in order to oppose the laws in states where they have a chance of passage. So that's one thing that I would say. And another is just finding your community of people who understand this issue and want to help. I would also say trying to be active in your state medical society, because this is often where proponents turn first to try to turn the tide of opinion.
I think I would agree with everything Joe says. And I think the biggest problem is that most medical professionals, like most of the public, have really not thought about this carefully. They're kind of limiting it to thinking about wanting a good death, instead of understanding or thinking about the potential ramifications of these laws and who would be vulnerable to them. And so I think it behooves those of us whose eyes in some ways have been open to kind of speak up and really spread the word, like Joe's doing and like you all are doing.
Let's say the compassion and choices people, it's very seductive, because you've got the stories of, oh, well, it's this and well, it's that, and you don't want anybody suffering. And why, and this is the most seductive, why shouldn't I be able to choose to do this? It's my life. Why are you forcing me to stay alive? Whereas what we need to do, or what we can all do and have been doing, is talk about how this affects not just a single person, but the entire country. Your entire community is affected by the choice, and how it is basically unregulated. Most people are surprised by the fact that assisted suicide doesn't go on the death certificate. And that anybody can be there. The doctor isn't here, but anybody else, including people who may benefit from your death, may be there.
Right. I want to say one thing, and one of the most moving experiences that I've had professionally is to visit patients in hospice at home, where I have developed close relationships with family members and with the patient. And I've intervened when need be, when I need to call the doctor to take care of things. it gives people an opportunity to come to terms and grieve together before someone dies, to say things to each other that they might not have otherwise said. And I find it a precious and cherished time if the person has to die, that they have it in a peaceful way with their family in hospice. And I will tell you that when some of my patients died, I cried, because you develop that kind of relationship with them. And so when we talk about physician-assisted suicide versus the palliative care and the dying process that can be made quite beautiful and pain-free, then we don't hear enough about that at this point to know that to choose that instead of physician-assisted suicide if death is inevitable.
Well, very good. Thank you all so much for your time today. I'm afraid we're at the top of the webinar time. Thank you to all our participants, all the panelists, and everyone in the background, our closed captioner, our ASL interpreters, and of course, thank you to Barbara Lyons, our coalitions director, for organizing all this. Joe had mentioned getting involved in your coalition, and also with your medical society. Contact us if you're interested as a medical professional or a person with disabilities interested in elevating your voice on this. There are often opportunities, and sometimes there aren't voices that can be brought forward. So I'm grateful for everybody for your time. I hope everyone has a wonderful weekend. Thank you for joining us, and we look forward to seeing you at the next webinar that's coming up in a few months.
Thank you, Matt. Nice to meet you all.
Likewise.
Thank you, everybody.
Bye-bye.
Bye-bye, everyone.
Have a great weekend.
Everybody.